Y'all, people are losing 40 pounds, 50 pounds, 60 pounds on a medication that they really don't understand that well. They really don't understand what it's doing inside their body. And they also don't know what happens to their body when they stop this medication or if they can ever stop it. So they're having things like hair thinning, or maybe your hair is falling out, or maybe you're losing muscle mass. And a lot of the information that people are getting, they're getting from Googling or even from places like TikTok. I am a board certified ambulatory care pharmacist, and I see this all the time when I talk to community members, when I go to clinic. I see it when I'm looking up information to teach to my students. And so today we are talking about what is actually happening with these GLP-1 medications like Ozempic, Wegovy, Mounjaro, Zepbound, what the science actually says about them, what your physician may not have had time to really talk to you about in your initial visit or even in your follow-up visit, especially if you got some other things going on. And we're also going to talk about the questions that you should be asking before you get your next refill. This is the Bridge to Better Meds platform. If you are new here, my name is Dr. Takova Wallace-Gay. As I mentioned, I am a board-certified ambulatory care pharmacist, and I'm also an academician, which means that I spend my days either in clinic consulting on patients, or most of my time is now spent in the classroom where I teach medical students, the future physicians, as well as pharmacy students. And I primarily focus on chronic conditions like diabetes, blood pressure, high cholesterol, heart failure, things like that, and talking to people about the medications that they take every day for those conditions. And so I really hope to bridge the gap between what individuals are being prescribed and what they understand about those, and just kind of making sure that those two things meet in the middle so that everybody pretty well understands these medications that we are asking y'all to take. And if you decide not to take them, you'll be better informed when you're not taking it. Now, there is a big gap right now when it comes to GLP-1s. And so this episode is going to be for individuals who are already on these medications, and maybe you have questions that you're nervous to ask or not really sure how to formulate that question. It could be for somebody who's considering starting one of these medications and just trying to figure it out based on information that you're getting from social media or information that you're getting from a family member. Or it could be from a family member who's looking at a friend or a loved one and thinking, I don't know if I should be concerned about this person or celebrating with them, but they are losing a lot of weight fast. So let's get into it. I want to start off by just defining what GLP-1 is. And so GLP-1 stands for glucagon-like peptide 1. And so GLP-1 is a hormone that our bodies already make. And so what happens is after we eat, GLP-1 is released in our gut, and it goes and tells the body to do different things. So it tells the pancreas to release insulin. Insulin is what takes sugar from your blood and puts it into your cells, like your muscle, so that you can use it for energy. GLP-1 also tells your liver to kind of chill out or calm down on producing sugar, because normally and naturally our liver converts the stored version of sugar into the usable form of sugar, regardless of what your blood sugar level is. And so GLP-1 is going to tell your liver, hey, you don't have to produce as much sugar right now. GLP-1 also slows down how quickly food leaves your stomach. So it just slows down the motility or the movement of food through your digestive tract. And it also tells your brain that you're full. And so I like to say that it works on 4 different organs, essentially. It tells your pancreas to make more insulin. It tells your liver to stop making sugar. It tells your gut to slow down the food leaving. And it tells your brain that you're full. And so all of these things together are what really help this medication work for weight loss, but also for blood sugar control. And so we've got a medication called Semaglutide, and Semaglutide comes in the brand names Ozempic and Wegovy. Ozempic and Wegovy are injections, but we also have a Wegovy pill version as well. We also have a Rybelsus pill version, and so I won't get into this as much in this video, but the brand name of the product that you are recommended is going to depend on what we're treating. So weight loss, there's certain branded products for weight loss from an insurance company standpoint. And then for diabetes, other of the branded products are specifically for diabetes. The doses are slightly different and they're marketed to those two different cohorts of people. So just keep that in mind. But the chemical drug in them is the same. So we've got semaglutide, and then we've got tirzepatide. Tirzepatide is Mounjaro and Zepbound. And it's a little bit different because it is a dual drug, which means it hits two different receptors. So not only is the GLP-1 hormone in tirzepatide, but also the GIP hormone is in tirzepatide. And that's also something that our bodies make naturally. But the reason why we tend to see weight loss numbers a little bit higher in the trials with Mounjaro and Zepbound, which is tirzepatide, is because we are hitting it from two different receptors. So those two hormones basically do the same thing, but again, we're kind of getting it double with that medication. So there are other GLP-1 agents that we don't use as often anymore, so I'm not going to talk about those in this video, but just know that Ozempic, Wegovy, same drug, Mounjaro, Zepbound, same drug. The difference is the FDA labeling and which one's approved for diabetes versus which ones are approved for weight management or weight loss, but they have the same active ingredient in them. And yeah, we just have to brand. We're branding for the insurance companies. We're not branding because the chemistry or the makeup of the drug is different. So if you are on one and your family member is on another one, the only difference that you need to be looking out for is if this one has GLP-1 only or if it has GLP-1 and GIP, because that's really the only difference. Now, I want to talk about some side effects with these medications. The side effects are definitely real. And the main one that we talk about is nausea, just because that's the most common one. And listen, if you've been on one or know somebody that's on one, or if you're thinking about starting one, you will more than likely experience the nausea. Part of that is because some people are trying to eat as much as they used to. Maybe that brain part hasn't kicked in yet, or because your gut is slowing down how quickly food is moving through. It makes you feel full. It makes you feel nauseous, like you want to vomit. So it's really, a lot of it is that slowed motility. We call that gastroparesis, but it's that slow motility, the delay in emptying of your stomach that can show up with these medications. And so if you also are someone who already has a slow gut to begin with, just naturally, or because you've got long-term diabetes that has caused your gut motility to slow down, this may not be a good option for you. It might make that exponentially worse. So just keep that in mind. But again, the nausea is a real deal. Usually people get over it in a couple of weeks, especially as they get through that first dose. But that's why that first dose level. So that's why we always start really low with the dose and then work our way up. You're never going to get started on the highest dose of a GLP-1 medication. And part of the reason is because we want to let your body kind of get accustomed to it and work through some of those side effects. Now, something else that is not that common, but definitely really important is pancreatitis. So if you've ever had a history of your pancreas being inflamed, then we're not going to want to give you this medication. We need to know that because it increases your risk of pancreatitis. As I mentioned, the GLP-1 hormone goes and acts on the pancreas, tells it to release insulin. So we are going and kind of talking to the pancreas with this medication. And so we're manipulating it in that way. We don't want you to have had a history of pancreatic issues and then we give you this drug. Also, if you have a history of gallbladder disease, if you're someone who struggles with severe constipation, you might have IBS or something else going on, then just be cautious because those things can land people in the emergency room. And you want to make sure that your healthcare practitioner, your physician knows about that upfront if you've ever dealt with any of those things. Now, there is another side effect that doesn't get talked about a lot, and that is hair loss. Now, this hair loss is usually related to rapid weight loss in general, not specifically because of the drug, but just know that because you are rapidly losing weight, that has to do with nutrients and things like that and absorption. You might have some hair loss early on. So that's just something to watch out for, to think about, and to try to mitigate as you go along. Talk with your provider about it to see if there are some things that you can do to slow that down, or if you do experience hair loss, there may be some things that you can try, even with your beautician or your barber. who may have some ideas of how to maintain or revitalize that hair loss if it occurs. And again, not everybody experiences this, but it's just something to note. Now, one of the side effects that I talk about a lot with people, I was just talking to a family member about this recently who excitingly went to the doctor recently and her weight was up. But her physician was like, it's not because of fat, it's because you've gained muscle. I had been talking to her about how she's on a GLP-1, but about how these GLP-1s, they help you lose weight. It doesn't specifically help you lose fat. And so when you lose weight, you're losing both muscle and fat. But we want that muscle because, especially in women, and especially in women of color, like I'm speaking to my people here as well, who already face a higher risk of metabolic conditions and things like that. But also if you are not a woman of color, our white counterparts experience higher risk of osteoporosis and frailty later in life. And so you want to make sure that you are maintaining as much muscle as possible, no matter who you are. From a male perspective, y'all, muscle mass is important for a lot of different things in terms of our health and our health perspective. And so you don't want to lose that muscle. However, with these GLP-1s, you are losing both muscle and fat. And so with that, you need to make sure that you are maintaining muscle in one way or another, ramping up your protein, doing strength training, a combination of the two. But you have to make sure that you're maintaining that muscle mass. So really important. I could harp on that forever and a day, but I'll leave it at that. Now, outside of side effects, I also want to talk about what happens when you stop these medications, because the information that we have in the literature isn't super clear about what happens or when to stop or if you can stop it. I get asked this question a lot too of how long do I have to be on it? People stop it and they're doing okay with their weight, but they notice that hunger signal picks up. And why in the world am I eating like this when I have not been eating like this for months because I've been on my GLP-1? And so when you stop that medication, a lot of people regain about 2/3 of the weight within a year. And that is not something that we look at as a failure of willpower or anything like that. It is purely pharmacology. It is purely the way that these drugs work on your hormones and your hormone signaling. If you take that signal away, the hunger is going to come back. The metabolism is going to slow down again. And so I want to be clear that these medications are not a cure for anything. They are placed here to intermittently or to intervene in an area where a lot of people need some support from a metabolic standpoint. And so while you're on the medications, work on those lifestyle things like the protein and the physical activity and all of that. And hopefully when you come off, those things are in place. And you may gain a little bit of weight, but ideally you wouldn't gain as much weight back if you stop it. And I would recommend that after doing a trial, you get to your goal weight or whatever, or you're on it for 6 months to a year, whatever you and your physician talk about, then take a break, take what we call a drug holiday from it and see how you do for about 3 months or so. Can you quiet that signal by yourself? Do you have habits in place that are going to help you maintain the weight loss that you've had? And so when somebody asks me, how long do I take this? My honest answer for most people is usually it's indefinitely, or until something better comes along, or until you've made substantial changes enough to maintain yourself on a lower dose or no dose. So you have to be able to make those changes with the diet and the physical activity, all of the lifestyle changes. And so that's a very different conversation than when we talk to people sometimes. We're like, oh, you'll be on this medication for 6 months, or you'll be on this medication for 12 weeks and then you're done. That's not the case here, because oftentimes these metabolic disturbances are considered chronic medical conditions. And just if you have any other chronic medical condition like heart failure, you might be started on a medication, or if you have a history of a blood clot, you might be started on a medication and be on that indefinitely, because we are actively mitigating your risk as we go. So for every person, that conversation is going to look a little bit different, but I definitely think that there are things that you can do to see if you're someone who, once you reach your goal, can you come off this medication for a certain period of time and see how you do. Now, the next thing I want to talk about is the compounded versions of these medications. So people, I feel like it's slowed down a little bit, but definitely for a while there, people were just going to any and every source out there and getting compounded versions of GLP-1s, either from a compounding pharmacy or one of those kind of mid-spa type places, or even an online clinic that would ship you a vial or a powder of some sort and all of that. And so I really just want you to understand that the risk profile with those things is different, okay? Those things are not as regulated as what we're getting coming from the FDA-approved sources. And so when we had a shortage in these medications, that allowed for this widespread compounding to start. And so we've kind of gotten to the end of that. We aren't really seeing that as much as we used to. That was probably one of the biggest questions I would have my students look up to see, what are they compounding this with? How are they doing this? And it's actually able to be sustainable in the body, because with hormones, not to get into the weeds on this, y'all, but with hormones, they have to be formulated in a certain way. Either injection or the pill has to be formulated very specifically so that your stomach acid doesn't destroy it before it has a chance to actually get into the body and do its job. And so I just had so many questions about how they were compounding it and all of that. But anyway, that huge kind of push towards compounding has ended. We were seeing a lot of dosing errors with that. People were getting 10 times the intended doses at times just because the concentration in milligrams versus milliliters is different, and they were thinking that it was the same or that it was more like a unit to unit conversion. So anyway, I think you just need to know what your dose is. Don't trust everything that you see. Vet whatever product that you're getting, even if you decide to get it from somewhere outside of your physician's prescription. Not that I'm not recommending that, but if you did, at least take the time to ask a reputable source, a clinician, about that. Get some information about whether it's safe or not, because I would hate for you to try something because it's cheaper or because it's available, and then it do you a disservice. And then that gets into my whole conversation about awareness, access, and action. I have a whole video on my AAA framework and really how all those things play together. But just because you have access to something and that you're willing to take it does not mean that it's the right thing for you to do if you do not fully have the awareness of what that medication could be doing for you or to you in the process. Okay. Now I want to talk about just like the cultural parts of this, because something that I don't think gets talked about enough in mainstream coverage or mainstream conversations with these drugs is the conversations that are happening in Black and Brown communities specifically. Black women have the highest rates of obesity in this country. The highest rates of obesity in this country are Black women. We also have the highest rates of being undertreated for obesity. And for many years, the message was fix your diet, incorporate some physical activity, try harder, eat less, move more. And we know that it's not that simple. Even PCOS has just been renamed PMOS, and that's a whole other conversation for another day. But we are just holistically recognizing that metabolic disturbances are an issue. And meanwhile, most often our white counterparts or other counterparts are being offered medications, bariatric surgeries, that the full toolkit of things at rates significantly higher than we are. And so now we have access to a class of drugs that genuinely works. It helps with the metabolic side of things. It helps with the weight, the blood sugar control, and the conversations in our communities are still very complicated. Some of us are still skeptical about these medications because we don't trust the healthcare system, and that system has historically experimented on people like us, dismissed us, gate-kept treatments from us. And while most of that isn't happening anymore, it hasn't fully gone away, but most of that isn't happening anymore, that the permeation of that historical nature still gets in and creeps into people's mindsets. And so some people are still very skeptical. Some people are jumping in without enough information, without enough awareness, because it's finally, you're offering me something that seems to be helping everyone else. You're giving it to me. I know it's going to help me. Let me just take it. And then others are watching family members lose weight and worrying. Are they sure that they should be on this medication? Oh, they looking kind of sick. You know how we get, oh, are you okay? And all of those responses make sense. All three of those responses deserve real information, deserve to be addressed strategically through education. And so if you're a Black or brown person considering one of these medications, here are some questions I want you to ask your provider. Number one, what is my A1C? So find out what your 3-month kind of report card of what your blood sugars have been running is. You also want to know your fasting glucose and, if possible, your insulin levels. Now, GLP-1s can be used even if you don't have high blood sugar, but you should know where you stand and understand what that number or what those numbers mean. Don't just get the number and go with it. Or don't just get the number and be okay with the fact that it's normal or slightly elevated. Get some context around what that really means so that you can determine how to move forward. Am I on the cusp of something? Do I need to modify some things that I'm doing? It could be a small modification in timing of your meals or types of meals that you're eating that could push you in one way or the other. And so then we know, again, are we treating diabetes, pre-diabetes, or are we purely treating weight? Now, the conversation is going to be different depending on what we're doing. So you want to know what your numbers are, but then also what's your plan for monitoring muscle mass? What's your plan for monitoring bone health while you are on this medication, especially if you are peri or postmenopausal? You need to be finding out, how are we going to monitor my muscle mass and my bone health? You could just go and have a scan done, like a body composition scan, and that would be perfectly fine. But talk to your provider, and maybe that's something that you can bring in. Maybe they'll set you up with a dietitian. Many insurances pay for dietitians, by the way. I see mine on a video once a month-ish. And yeah, find out how you're going to monitor those things. And then also, you want to find out, what's the off-ramp? If I stay on this forever, what's the maintenance plan? If the plan is not to stay on this forever, what's the discontinuation plan? So just figure some of those things out up front. Even if they don't have the full answer for you, you need to start that conversation, and then that conversation will continue and continue as your visits go along. Now, I also want y'all to understand that, as I mentioned before, titrating on these medications is not optional. You can't just say, my cousin is on this dose, start me there, because that's the dose that's working for her. Oh, I'll be fine, I won't have nausea. Not an option. The doses are going to go up slowly for a reason. People who skip that titration step or push to higher doses faster are the people who are landing in the emergency room with pancreatitis, gallbladder issues, things like that, because your body needs time to adjust. The hunger reduction at the lower dose may be all that you need. You may not need to titrate. And the studies are showing the titration with the max amount of weight loss average, but some people lost weight on lower doses as well. And so keep that in mind, that you may be in that category. Number 2, hydration and protein are not optional. I've talked about the protein. I've talked about the muscle loss. You have got to hydrate. Water, coconut water. I don't mean hydrating with sugary beverages and things like that. Don't let these companies gas y'all up. A friend of mine asked me recently, he was telling me that he drinks a certain type of drink. I won't list any brand names, but it's marketed as this healthful drink. And I'm like, it's got a lot of sugar in it. And so make sure that you're watching out for that and hydrating with water, things that are going to fuel your body, and also protein. So I would say for most people, 5 to 10 grams of protein per snack, probably somewhere around 30 to 40 per meal. But again, I think you need a dietitian for that, or talk to your healthcare provider. Also, know that when this medication slows your stomach down, you are going to eat less, which means you are also going to drink less. So we're seeing a lot of dehydration in patients, kidney injury, electrolyte issues, things like that. So make sure that you're aiming, again, for plenty of fluids. Drink water like your life depends on it, because it might. Drink water like it is your job and you're going to get paid to drink it. And aim for, again, this is just an average, somewhere around 80 to 100 grams of protein per day, just to protect your muscle. The third thing to note is that you need to know drug interactions. Oral medications are going to absorb differently when your stomach is empty or when it's emptying slowly. So you've got things like birth control pills. The labeling for Tirzepatide specifically advises using a backup method or switching for the first 4 weeks after each dose increase, because we know that those medications aren't going to get absorbed as well. If you are on levothyroxine for your thyroid, timing is going to matter even more now. If you're on the sulfonylurea or insulin for diabetes, your hypoglycemia risk is real and really important to think about. So your doses may need to come down on those medications, again, because of the slower absorption and slower motility of your gut. Also, don't forget storage with these medications. The pens need to be refrigerated until the first use. After that first use, most of them can sit at room temperature, but it just depends on the product and which ones you use. So I always feel the need to say this: don't leave it in a hot car in Texas. Don't throw it in your gym bag. Don't put it in the freezer. No extreme temperatures. It denatures the protein or breaks down the protein in these drugs. And so we know that it's not going to work if it gets too hot. And then freezing it is just going to destroy the product altogether. You don't want to waste your doses. These medications are expensive. Store them the right way. And then finally, I want to talk about insurance coverage. So insurance coverage is still a little bit of a mess. I think it will continue to get better as we have more and more products available, but it's still a little bit of a mess, and each insurance covers them differently. They switch coverage from time to time. Wegovy and Zepbound, again, are for weight loss, so most plans don't cover them, or it's going to require you to fail other things first. So you would have had to be on some of the other weight loss medications. I have a video all about weight loss medications. Check that one out. But you would have had to try some of those before it will pay for you to get Wegovy or Zepbound. And then when it comes to Ozempic or Mounjaro for diabetes, most of these are covered, but oftentimes require a prior authorization. And that's just a process that we can't help, y'all. That's an insurance thing. And so your physician will call it in. Sometimes he or she will already know that it's going to require a prior auth because they've seen it before. It gets to the pharmacy. The pharmacist goes to fill it. They probably already know it's going to need a prior auth as well, but you have to run it through the insurance before it kicks back to say you need a prior authorization. And so once that happens, then it goes back to the insurance company, and then it has to go back to the physician office to fill out the prior authorization paperwork, and then the pharmacy can fill it. And so we can't skip these steps. The pharmacy can't skip that step. Your physician can't skip that step. That's just the way that it is. And so just know that we're not trying to delay treatment. Most offices have gotten really efficient with prior authorizations because they're so used to seeing them. But just know that it could take a little bit of extra time if you have to have a prior authorization. And then I don't think Medicare covers GLP-1s for weight loss at all under their current criteria. And so if you're someone who has Medicare, then you may not qualify for the lower cost coverage with the GLP-1s. And so we see these kind of two tiers of the system. People with money are sometimes paying $1,000, $1,300 a month out of pocket, or getting compounded versions for a few $100s. And then people with lower resources are either doing without, or they are trying to find creative ways to get the medications through patient assistance programs, things like that. So this is all like a systematic issue where we are trying to piece together what works best for each specific person with all of these different insurance programs and different levels within the insurance programs. It's just a lot. And so your clinicians are doing the best that they can, I'm sure. But just go in there and ask the questions. You can also call your insurance company and talk with an advocate at the company to find out how to get this medication covered for you, or how to get it covered sooner so that you don't have to try as many things. If I could give you one thing from this video, it would be that I want you to try to bridge the gap between starting a GLP-1 and actually getting the outcome that you want from it. That looks like not letting weight loss be the only thing that you measure. Let me be clear. Again, do not let weight loss be the only thing that you measure. You need to be looking at your blood glucose levels, your A1C, your muscle mass, your kidney function, all of that. All of the things that are going to change as your body and your weight shifts. You need to make sure that you are changing with it in order to prevent risk, or reduce risk, I should say, and also in order to preserve function over time and preserve the weight loss over time. Measure your protein protein intake, measure your strength, measure your sleep. Think about how your body is feeling overall, because the people that I feel are thriving on these medications long term are the ones who are using these medications as a tool to build a different relationship with their bodies, to build a different relationship with food and movement, not using it as a shortcut around it. Share it with somebody who is on a GLP-1 or is thinking about starting a GLP-1. And then also, I have a guide I'm going to put in the description box that talks through some of these GLP-1 agents, and download that. Let me know what you think about it. Until next time, thank you.